Good evening, everyone. So, on behalf of Indian Pharmacological Society West Bengal chapter, we are very glad to host this physical meeting. Though it is also for our friends, we have make it in hybrid mode. So, after a long time, we met physically, and today we are going to have a long discussion about different aspects of hypertension management. So first of all, there is one announcement that uh, due to some family reason, Professor Tanuka Mondal sir cannot join us today. Uh, we will directly move on towards the scientific events. So for that, we are really glad to have Professor Amit Ghosh, who is a very senior professor of pharmacology now in IPS SSKM Hospital. So may I invite sir to chair the session, and Dr. Shabnam Ara Begum is coming. She will join us later. So may I request Professor Amit Ghosh sir to proceed for our first lecture.
Good evening, everyone. Respected senior professors, my colleagues, and other students and teachers. Today, this auspicious evening, we are going to discuss several topics about drug testing as well as clinical speech in the aspect of pharmacology. Now, first speaker is Dr. Raja L, Assistant Professor, Department of Veterinary Pharmacology and Toxicology, Healthsoft. Now, short biography of Dr. Raja L. He is a Bachelor of BBSc in Tanuka College, Chennai at the year 2007. Now he is in BSc from Durg, Chhattisgarh in the year 2012, and now he has done his PhD from West Bengal University of Animal and Fisheries Sciences, Kolkata at the year 2007. From the year 2007 to 2019, he has acted as assistant professor at several veterinary college Ranchi, and in the year 2009 from till date he is assistant professor in WBU AFS. His research work on behavioral science. He presented his paper at Animal Behavioral Science Conference, USA, at the year 2020. Now he is working on anxiety animal model at the department. Dr. Raja, please.
Thank you, sir. So, respected dignitaries of the dais, respected General Secretary, President, Vice President of IPS West Bengal chapter, respected professors, teachers, and doctors, and above all my students who are all assembled here. Good evening to all of you. At the outset, I'm thankful for the organizers of IPS for giving me an opportunity to share some of my views regarding the animal model development for antihypertensive drugs. So we will go into this topic. First, let me share some of my views regarding animal model development for any aspect. This hypertension is one of the most common chronic disorder affecting millions of people around the globe. So if you look into any journals, there are many drugs which shows they are highly efficacious, herbal preparations or whatever may be. They show it is having a highly efficacious in preclinical data, but none of them, or very rarely, few of them make into the clinical trial. So something is fundamentally going wrong in there. Until this has been corrected, there will be a wastage of huge of the manpower as well as the resources. So let us have a very brief overview about animal model. So in order to validate any model, there is three things has to be done. One is face validity, another is construct validity, another is predictive validity. What is this face validity, construct validity, predictive validity means? For example, if you are modeling for any diseases, then the symptoms, one of the core symptoms or any of the related symptoms which is presented in ICD-11 manual should happen in your model. This is a very mandatory. Only then we can say that developed model is having face validity. Second, what is construct validity means? The etiology or mechanism of the disease should be similar in both the human beings as well as in the model. A clear-cut example I can say, for example, hyperglycemia can be induced due to insulin insufficiency as well as due to the excess of steroids. Suppose if you look at if a model hyperglycemia developed due to a steroid model cannot be a appropriate model for studying diabetes. So because the fundamental the etiology is different. So that is why either the etiology or the mechanism of the disease that is happening in humans should be similar in case of animals also. Next one, predictive validity. In predictive validity, the pharmacological drugs that are used for treatment in the human beings should have the same response in case of the animals models. Otherwise, the predictive validity is not there. So until a model is having both phase, construct or predictive validity, it is not a complete model. Now, there may be so many models. How can I choose the best model among them? So for that, there is a scoring system which is universally followed. That is depending upon species, disease simulation, phase validity, complexity, and predictivity. So based on that, your score has been generated and we can use to compare between every models. Now, hypertension, as we all know, there is fundamentally classified into two. One is a primary and it is a secondary. Although we do not know the exact cause for this primary hypertension, there are some contributing factors like high dietary sodium, obesity, advancing age. These contributes to that. So when we do not know the causative factor for the primary hypertension, then we cannot able to develop a model and can have a construct validity because that requires an etiology. When we do not know the etiology itself, how can we develop a model based on the construct validity? So this is the first drawback for this primary hypertension. Secondary hypertension, as we all know, it may be due to some renovascular diseases, renal diseases, and endocrine diseases like hyperaldosteronism. All those things may be the reason for the secondary hypertension. Now, let me go into our topic. Why rodent model? The pathogenesis of hypertension in rats and the humans are largely similar in terms of arterial pressure development from childbirth and as well as the responses to environmental stresses, vascular resistance, and the mechanisms regulating arteriolar and venous constriction, including your sympathetic nerve activity as well as ROS and nitric oxide pathway responses to that is almost similar in case of rats as well as in humans. So that is why we are choosing rodent model. And moreover, the CPCSCA strictly regulates and discourages the use of large animals, particularly dogs and cats. So we have to rely on the rodent model. Now, how I will measure this BP? This is very important. So whatever model I develop, first I need a parameters. For that, the measurement of the BP is a very important thing. There are three methods. Actually two methods, invasive and non-invasive. In non-invasive, we can further use a tail cuff method or radio telemetry method. See, invasive, this is a very gold standard method. It is placing the intra-arterial catheters. But this has to be done by a very fine person. Expertise is necessary. And this is very suitable for studying certain agonists or antagonists. If you want to study the effect of drug on the vasculature, then this invasive method is the preferred method. Suppose if you want to screen any drug for the antihypertensive activity, then we can go for this tail cuff method. So in tail cuff method, the rats are reliable. Means if you're using a tail cuff for rats, it is more reliable. Mice are there's a huge variability, and we cannot rely this tail cuff method for measuring BP in case of mice. And in rats also there are some issues, heating issues, and this restraining issues. All these things has to be corrected, and the values has to be adjusted. Now, what will happen in mice? How can I screen this antihypertensive in mice? It is best to go for radio telemetry method. But all these are very costly methods. So, professor from AIMS, they developed an alternative method using our own sphygmomanometer, and they have published the paper, and that is having more reliability like tail cuff method. So, but it has to be validated further. But they have published the paper, and they say that it is one of the alternative for this tail cuff method in terms of cost, because this tail cuff is very costly, and all the departments may not be in a position to affordable for them. So they have suggested this method, and we can go into it. So regarding the animal models, there are we can classify into two broadly. One is essential hypertension or primary hypertension models, and secondary hypertension models. So for this primary hypertension models, we have genetic models, environmental models, pharmacological models, and for the secondary hypertension, we have physical models. So first we will go for this physical models. So in physical models, we have many models like 2K 1C, 2K 2C, 1K 1C. It's basically we are applying a clip towards the in the renal arteries. Thereby, the constriction of this renal arteries produces a stenosis, and this stenosis is similar to that of what is happening in the human renal arterial stenosis. There may be many kinds of stenosis. See, in 2K 1C model, one of the two arterioles, renal arteries, is constricted by the clip. And in 2K 2C model, both the renal arteries are constricted. In 1K 1C model, in one of the kidneys, we will perform a nephrectomy. So only one kidney is left. So in the unilateral kidney arteries, we will applying a clip. So this is the another model, 1K 1C model. So in these models, if you look into it, what is the futures? It is there means in 2K 1C model, there is an increased plasma renin activity initially, and then it will become stabilized, and then there will be chronically increasing. The similar pattern is observed in case of human beings. Those people who are having that renal stenosis, either unilaterally or bilaterally, will have the same. Initially, there will be a rise in the plasma renin activity, then it will become stabilized, and it will be chronically once again rising. So the same features are mimicked in the rodent model. So it can be used for studying these kind of hypertension. If you want to study hypertension or drugs efficacy in case of renal stenosis, then you can use this kind of models. And there is another model, renal parenchymal hypertension model. In that, what you have to do is we have to go for a subtotal nephrectomy. Nearly most of the kidneys we have to remove, and that will induce a chronic hypertension. So the kind of hypertension developed is more dependent on RAS system, and this can be reduced by ACE inhibition. Next one, in case of essential hypertension models, we have this spontaneous hypertension model. In this spontaneous means we do not have to give any drugs, nothing. The rats by itself will develop hypertension. How they have developed this? We have to take Kyoto strain blister rats, and we have to do a brother-sister mating. So the offsprings have this hypertension, and this elevated this hypertension will be around 180 to 200. So this spontaneous SHR, commonly it is abbreviated as SHR rats, they are used for studying stroke, how hypertension is causing stroke. If you want to, if a researcher is interested in that angle, then they can use these SHR models. And it is also used for studying the target organ complications. And next is a Thal salt sensitive rats. It was developed by the scientist Lewis Dahl. So it is basically cost effective inbreeding of Sprague Dowley breed of rats. In this, what is happening? We have to, you have to choose which strain of rats is salt sensitive and salt resistant. So those rats which are salt sensitive, we have to feed 0.45% of salt in their diet to induce hypertension. So the reason for development of hypertension in Thal salt sensitive rat is there is a decrease of atrial natriuretic factor and as well as increased ACE. That is a reason for which the beyond the development for the development of the hypertension in this. Next, we can also have another models like fawn-footed rats, Milan hypertensive, lion, sabra. So it's all basically they develop spontaneously hypertension without any surgical intervention or drug intervention. Just it is a inbreeding strains, and depending upon the requirement of the researcher in which area he is working, then he can choose the particular strain of rats. For example, fawn-footed hypersensitive, it is a model for renal parenchymal disease. And in case of Milan, this rats develop hypertension soon after weaning, and later it subsides. The hypertension is persisting only for a shorter period of weeks, and then it will subside. Whereas in case of lion, so it is also developing hypertension, but it will not subside, it will sustain. So depending upon the requirement of the researcher, how long he wants to study, he can accordingly choose the particular strain of rats. Now, environmental model. In environmental model, we all know that the cold also induces the hypertension in case of humans. So we can also mimic this kind of hypertension in our animal model by subjecting the visitor rats to 5 degrees centigrade in laboratory conditions for 3 weeks on a periodically. So if we do that, then after 3rd week, the animals do develop hypertension for cold exposure. And in them, we found that there is a higher amount of RAS as well as the sympathetic activity is more. And that is the reason for the development of hypertension. And this increased the RAS and renin-angiotensin-aldosterone system and sympathetic activity is also present in those people who have cold-induced hypertension in case of humans. So this is an appropriate model for studying these kind of hypertensions. Next one, we all know that obesity is a contributing factor for development of hypertension in case of humans. So we have models for that category also. So suppose if a researcher is interested to know what is the role of obesity in hypertension, then he can choose this. So we have 2 categories of models in this category, in this heading, obesity. See, models of obesity. See, these are genetically induced obesity models by gene knockout technology of leptin, coding for leptin. We developed this mice, certain rats like Zucker rat, ZFF1, Mr. Fatty rats. So in these models, obesity develops spontaneously because there is a mutations in the leptin, so there's a spontaneous development of the mutations. Whereas there is another way to induce this obesity. So that is by feeding high carbohydrate or high fat diet to the rats, it will induce hypertension within 3 weeks. But you should this is not possible in case of mice because it will take more than 3 months to develop. So rats are ideal for developing obesity related models. And in spontaneously developed obesity, you can study the mechanism by which obesity predisposes the hypertension. In case of superimposed models, like the second category, so you can take a Dahl sensitive rat or a spontaneous SHR rats, and you can continuously feed this high carbohydrate diet, and then that will become obese. So there is already a hypertension, now you are inducing obesity. So in this kind of superimposed models are used for studying how the obesity is altering the already existing hypertension course, disease pathogenesis. So in either way, these obesity-based models are useful. And pharmacologically, how we can, by giving drugs, how we can introduce certain animal hypertension models. One is nitric oxide deficient model. Next one is mineralocorticoid salt hypertension. And third one is continuously giving angiotensin 2 for 4 weeks subcutaneously. We can develop the animal, hypertensive animal models. See, only one important point I want to stress in case of a nitric oxide deficient model. See, if we can superimposing this nitric oxide deficient model with conventional diabetes, this accelerates the kidney injury, and this is an appropriate model for studying the human diabetic nephropathy. So these are some of the drugs to induce hypertension. And now, so whenever hypertension is going on, there is a remodeling of the vasculature, particularly in arteries, goes on. So I just don't want to go into deep this kind of SHR or Dahl sensitiveness. What is a kind of remodeling? It has been going on in a different strains of rat has been also categorized. So suppose if a researcher is interested in studying the, for example, hypertrophic remodeling, then he can choose that particular method of induction of hypertension, and he can go for it. Now, we all are maybe interested about the atherosclerosis model. Unfortunately, rats and mice are not good models for atherosclerosis. There is some reasons for that. These rodents are typically resistant for this atherogenesis. And second, the lipid metabolism is most based on HDL rather than LDL. And often we have to supplement this vitamin D3 for atherosclerotic calcification. For these reasons, rats or rodents are not a good model for atherosclerosis. But anyhow, if we want to study this atherosclerosis problem, then we can go for some gene knockout mice like what we have given, ApoE and LDL receptor lacking mice. So these can be used. But there is another way for induction of this atherosclerosis model. First, we have to take the Sprague-Dawley rats and we have to go for an ovirectomy at the 16th week before that. And then by giving 15% of heated vegetable oil, because that is one of the repeated usage of the oil is the reason for the development of atherosclerosis in case of humans. And the same way, we can also give this heated vegetable oil administration. This will lead to the development of atherosclerosis in case of female rats. See, the critical point. The critical point is, yes, okay. I'll just finish off. This is the last slide. So the critical point here is this atherosclerotic model can be developed only in the ovirectomized rats. If we do not do this, then the natural female hormones will protect from the development of this atherosclerosis. And if I want to try it in male rats, then it has to be fed for more than 24 weeks. Then only this atherosclerotic plague is developing. And hence, normally the female Sprague-Dawley rats has been ovirectomized and it has been fed with heated vegetable oil. And that is leading to the development of atherosclerosis. And in this atherosclerotic plague which has been developed, that is very identical to that of the humans. Like there is a increased serum total cholesterol, and there is more pronounced focal disruptions in the aortic intimal layer, and also the mononuclear cells were also present. So I'd like to conclude it. So the animal models have been and will likely remain very useful in providing insights into the pathogenesis and the novel treatment options for the hypertension. But the key feature of the human hypertension, that is its association with the comorbidities like obesity, diabetes, and heart and kidney problems, which influence the disease characteristic and outcomes, Currently, this cannot be incorporated into the animal model. So the choice of animal model, like whether I have to use a rat or mice or small animal, large animal, or whether I have to induce it with the drugs, or I have to choose a spontaneous developing hypertension rats, will largely depend upon the experimental's question and investigators' available resources and the expertise. So no individual animal model will recapitulate all the features of hypertension, and all models have their own advantages and disadvantages. So with this, I just want to, these are the references for this. I just want to conclude my speech, and thank you so much for the time.
Thank you so much, Dr. Raja, for such a nice and informative speech. And I'm really, it is very informative to me also, because I'm right now in Achintya Medical College. And in Achintya Medical College, one of our PG's topic is always that is diabetic model we have along with hypertension model. So it is very helpful for them also. They are also on online.
Okay.
And I think actually that model was on by speculation, they have developed diabetes and also by diet. That carbohydrate fat, they developed always that, and on that hypertension, obesity induced hypertension.
Okay.
And that thing also, and how, I want to ask you, whether there is association, we also know that hypertension and diabetes are related.
Yes.
And in that case, is there in your studies, or you have gone through such things like whether diabetes and hypertension, that kind of model may track? So how much it is possible, or it is feasible?
Means you are asking me, first we have to develop a hypertension superimposing with the obesity.
Diabetes.
Okay.
Diabetes, and also by obesity, by obese model, then they develop whether they are hypertension develop or not.
Okay, ma'am. In case of obesity induced hypertension, first we have to try it. We have not worked in that area, so we cannot able to say anything. But we assume that if the Kyoto Vista strain of rats has been used, then it is very easier for the development of hypertension, essentially hypertension. But in case if we are going for this diet-based model, as you were asking, then we have, within 3 weeks, it is possible to get it the hypertension. And if it is not developed within 3 weeks, which means the hypertension is not developed. Time period in case of rats. Thank you so much.
Anyone from audience?
Okay. Okay. Thank you, sir. Thank you.
Good evening. Now we have the proud privilege to get announced Dr. Achintya Mitra. He is a research officer in Scientist 3 at Central Council for Research in Ayurvedic Sciences under the Ministry of Ayush, Government of India. And he is a highly knowledgeable person in Ayurveda, and he has more than 100 publications. And he has also conducted more than 20 research projects. And he will now give his lecture on plant products and the effects of BP control. Thank you, Professor.
Very good evening and namaskar, respected chairpersons and dignitaries present in this gathering. So today I'll discuss on this topic that plant products and the BP control, blood pressure control, which is given by the organizer. And I'm very much fortunate and thankful to the Indian Pharmacological Society of the West Bengal branch for giving this opportunity. So as you know, the plant products or plants are being used since times of immemorial, and the Vedic period, since we have documented evidence since the Vedic period. And as you know, there is a recognized system of medicines which is recognized by the government of India, particularly in a country. There are 6 systems of medicines approved, and most of the systems are using the plant products of different forms, the Ayurveda and the Unani system of medicine, Siddha system of medicines, and another is for the Swarikpa system of medicines that is recently recognized by government of India. And as you know, the yoga and naturopathy, they are not using any medicines or the products. So first of all, not moving slides. Okay, just quickly we look on this the hypertension or BP, blood pressure, high blood pressure. That is a particular term of hypertension is not mentioned directly in any classical books, but the symptoms and the disease conditions is written many places in the Ayurvedic classical books like Charak Samhita, Shusha Samhita, Bhagavad, and other classical texts. So here the ban bath, typically the physiological intrinsic factors are considering the 3 factors. Among them, the bath of Prakriti is also there. There are also 5 types, and another type is the ban batha that is responsible for movement of Rasha Dhatu, Rakta Dhatu, like that. It is mentioned in classical texts, and on the basis of that, if there is a vitiation of this particular intrinsic factors, there may be Rakta Dhatu Dushti, and that's why the hypertension can be caused. And the alteration of the circulation may be due to the obstruction of the vessels, either by the constriction or by increased the hardness or the loss of elasticity. And aggravation of this particular the factor which increase the roughness, hardness of the vessels and producing the constrictions. And the accumulation of the unwanted material like bad cholesterol also inside the vessels reduce the internal passage. And some factors also responsible is mentioned in classical text. There's a loss of the Uribana and Monobhav Srotas. That is the you can consider as a central nervous system, and Vatavah Samsthan and Mutrabhav Srotas also considered somewhere. And if you consider this Hridaya, that is the heart, is mentioned in classical texts, and the nomenclature also given. Hri means the horon, and which carries the indifferent nutrients required for the body. Da means that gives away nutrients to the dhatu or the tissues, and Y means the continuing process and invariably till the person dies. This is the Ayurvedic perspectives on that blood pressure. Now the hypertension is the similar condition mentioned in class, because it is important, because whenever you go through the classical text, it is not particularly mentioned the plant product used for hypertension. Maybe there is some synonyms. So there is so many synonyms mentioned in classical texts like Dhamani Paripurna, that is given by the Mahamahopadhyay Karunath Sen. And then Ban Bala Vaishama, it is widely used, which is resembled to the hypertension, essential hypertension. And Dhamani Parichaya, it is also mentioned by Chakrapani Datta, the great commentator on Charak Samhita. Siragata Bhat, Pitta Brita Bhat, Rakta Brita Bhat, Pitta Brita Udana, Panabrata Udana, and Rakta Gata Bhat. These are the synonyms mentioned in different places of the Charak Samhita. Now the factor control for the blood pressure, which is mentioned in our classical text, that may be acquired, but Nijo Hetu, that is mainly on the Mitra Ahar and Vihar. That is a faulty diet and also lifestyle. Aharaja means the excessive intake of the Ruksha, Shita, Laghu, Ashatma, Viruddha, Bhajana, excessive fatty substance, heavy substance, and excessive intake of the salt and the pungent substance also may cause the hypertension. And on the lifestyle modification, we can say the causes are the excessive stressful work, Ratri Jagaran, it is happening nowadays. Diva Shabna, that means the daytime sleeping. And Deva Vidharana, suppression of the natural urges, Marmavighat, the injuries, and the Vishama Pachara. These are the causes which may the triggering factors for blood pressure high. And Agantoja Hetu, that is the external cause, is the violent action, the repeated fall, and the thoughtless action, and Obishangal, that is such as Kam, Chinta, Krodh, Shok, Bhoy, Aghat, like that. And other factors like that, the Ayurveda and the other system of medicines under the Ayush, that is where the personalized medicines, means it is a Prakriti is a very important factor. Some Prakriti having the tendency of that hypertension, particularly the individual constituents, the strength and the enzyme activities, age factor also, and the mental status. These are the other factors also directly involved with the blood pressure. And other predisposing factors like the obesity and alcoholism, excessive intake of salt, smoking. These are the factors mentioned in our classical text. Now the management is a two-way broadly, is a preventive or prophylactic therapy. By this some practice we can prevent, because in particular Ayurveda, the main emphasis on the prevention, and another is curative therapy. Some medicinal plants which is proven for the through the different clinical studies like that. I'm just telling few of these them. Sarpogandha, the Raulfia serpentina is widely used, root is widely used, but Rokto Bhara Shamaka, and Mutra Birachina, the diuretic also they are using, like Punonova, Borbia diffusa, Gokshura, Tribulus cristis, Push. This kind of the plants also used as the diuretics and directly as the home remedies, and also sometimes prepared medicines also available. And Shanga Sthapana, that is a Bacha, Acorus calamus, and Jota Mangshi, another medicinal plants. Also, we are using Medohara, drug like Loshuna, garlic, Gugula, Methi, or fenugreek. We are using Ridda, which is cardiotonics, Arjuna, and Terminalia Arjuna, and Vedana Shamak, some medicinal plants like Gugula, Rashuna, Tagara, not Tagore, Tagara, this is a higher altitude plants. And the Rashayana as a whole comprehensive approach, we are using some medicinal plants, Ashwagandha, Shatabari, Amloki, Horidati, like that. Now, few plants I left to, these are Arjuna plant, widely used as a home remedies, also some medicinal preparation also available. Terminalia Arjuna, and the stem bark generally we are using. It contains the tannin, arginine, and essential oils. Important because another synonym for Arjun is Partho. The Partharishta is also available. Nagarjuna Pradosh, Arjun Krita, and as a simply dry powder of stem bark of Arjun also using, and with the fortified with milk as a cardiotonic. Sarpagandha, Raulfia serpentina, that is under the Apocynaceae family, root is using, and there is a dozens of alkaloids available. The reserpines also important alkaloids. And the important formulation is the Sarpagandha Gunavati and Sarpagandha Mishran. Till we are using in our practice, daily practice, Sarpagandha Gunavati. Bacha, that is the Acorus calamus, Acacia family, and dry rhizome is using for this purpose. And there are so many classical formulations also available. Among them, Sasara, Satarishta. This is very important. Chandrapavati like that. Hingu Churna like that. Plant product formulations also available till now. Jota Mangshi, this is a high altitude plants. And Jota Mangshi, that is a very important plants, and dried rhizome we are using, and full of essential oils. And Jota Mangshi Orca means it is as it is a rich of essential oils. So we are preparing some formulation by the distillation. Brahmi, it is widely available here. Arkopal moniari. This is also using for this control of blood pressures. Brahmi Krita, Sasatarishta, Sriti Sagar. These are the common formulation. And also nowadays it is widely cultivating in our state. As you know, and also exporting these plants, widely exporting from West Bengal. This is a natural habitat West Bengal. So recent some clinical trial we have conducted by this our council, working in the last 17 years. Sarpagandha Ghanabati, Prabhakar Bati, Brahmi Bati, Kapuradi Gagul, Chandraprabha Bati, Jatismati, oil, Ashwagandha Churna, Shatabari, Arjun Khirapak, Arjun Tak, and there is also some regimen, Takuradi Churna, Jatamanshi Churna, Arjun Tak, and combination, and Usiradi Churna and Jatamanshi Churna. There are so many trials already conducted. Among them, only one trial I just explained because my domain is a clinical trial in Ayurvedic system of medicine. So like that, the study one, there is a Bocha, Brahmi and Jatamanshi combination, and 1:1 from ratio. Powder 3 grams size daily were giving for 3 weeks, 6 weeks, and sample size was 898, and OPD level study we have conducted. And another group, there is a Chandraprabha, Seth Korpoti and Punanava Amondu. These are the herbal mineral compound, not purely herbal or medicinal plants, having mineral products also. 500 mg thrice daily, 6 weeks trial. Sample size was 663, and OPD level study. Another study, there is a whatever drug we have used in the group 1, that along with we have given the yoga and meditation also. And we have given the common yoga protocol standardized to the patient. And that's it also 6 week study, but sample size was 37 only. And these studies was carried out in the multi-centric mode, the 15 center all over the India. There are some inclusion and exclusion criteria. The hypertensive patient, either sex between the 35 to 70 years have taken, and having no complication of the disease, and patient having the blood pressure 152 and 90 millimeter mercury and higher, and duration less than 15 years. And exclusion criteria is below the 35 years and above the 70 years age, having systemic or serious complication of cardiovascular, cerebrovascular, or any renal systems, hypertension, retinopathy, malignancy, liver diseases, and patient also responding with this salt restriction or avoiding mental and physical strains also avoided. And if the duration of the disease is more than 15 years, also excluded from this study. So some results, there is the comprehensive study I've just mentioned. This is on the basis of the blood pressure control. The systolic pressure, if you see, this is a study 1. Before treatment, there is a 162 mean value. After treatment, there is 140. And diastolic also 110. And after treatment is 89. And if you go to the study 2, there is also the before treatment, there is a 162. And after treatment, 141. And diastolic also 110, reduced to the 89. And in the result 3, study 3, which is having the medicinal plants, also we are giving some lifestyle modification through the yoga and meditation. That is also 162 mean value, that is reduced to 138, and also diastolic pressure 100 reduced to 85. So this is just on the basis of this, and the book is also published on the essential on the plant products use through, and also result getting through the different clinical trial. This book is also available with CCRS. But some plants, there is a misconception that the plants also always safe, but it is not like that. Some medicinal plants also may cause hypertension. We have seen the repeated and prolonged use of the Joshti Madhu, that is the Glyceria gabra, that is also causing that hypertension. And like Shomlata, also we are using in regular practice for bronchial asthma, ephedra. It contains ephedra. Also, if you're doing getting these medicines a long time may cause the hypertension. Excessive intake of citrus fruit, lemon, naturally there a particular condition is there a secondary hypertension. It may cause excessive intake of the dry herbs, which contains the high content of potassium, may cause also hypertension. And nowadays also IHS also observing this pharmacovigilance. The newer drug is also coming, and usage of herbs also increasing by 7.5% as per the report. So drug herbs interaction, the new area also we are observing, that is also taken care. And thing is that the plants always we have to use through this prescribed mode and also not in a home remedies. Okay, thank you. Thank you.
Thank you, Dr. Abhijit, for your nice presentation. I have a very little idea about IPS nutrition. From the very beginning only, I had that short one.
Yes, yes.
Okay, but your presentation makes us agree how many drugs you are using in Ayurvedic medicine. It is very nice that primarily we are getting the drugs.
Yes. Thank you.
Now we request our chairperson, madams, Professor Shikha Bhattacharya, madam, and Dr. Kovina to hand over the token of appreciation to Dr. Achintya. Now we request our teacher, Professor Tanuka Mondal, sir, to hand over the token of appreciation to Professor Shikha Bhattacharya, madam. And also please to hand over this certificate of appreciation to Dr. Kovina, madam. So now we are moving to our next session, and to chair the session we have Professor Abhijit sir, who is the professor and head of pharmacology at Bardhaman Medical College, and also we have Professor Swati Bhattacharya, madam, who is the professor and head of pharmacology at Raiwan Medical College. I request Madam and sir to please share this session on resistant hypertension.
So very interesting topic, resistant hypertension, and also the speaker is also a young and energetic Dr. Abhijit Ganguly, assistant professor in the Department of Pharmacology and Therapeutics, Tanuka Mondal. Service in Ganguly long 11 years, and he also completed BM Pharmacology in the year 2018, I think so. And he has also many publications, national and international journal. So, without much delay, may I request Dr. Ganguly to please go forward this interesting topic of resistant hypertension.
Good evening, respected chairperson, sir and madam, and other dignitaries. I'm going straight forward to the topic, the resistant hypertension. First, our objectives, our goals. Goals of this discussion will be discussed in three parts. First, definition and epidemiology of uncontrolled resistant hypertension. Then discussion about diagnostic algorithm of resistant hypertension. And lastly, overview of new therapeutic option for resistant hypertension. Now coming to definition, uncontrolled hypertension, just like definition of hypertension. Blood pressure above the goal less than 140/90 for general population, adults age 18 years or older, less than 130/80 in patients with diabetes or CKD. Classification of blood pressure in adults. Now, classification of blood pressure in adults. In brief, you all know about this. Normal blood pressure less than considered as less than 120 and less than 80 diastolic blood pressure. Pre-hypertension in between 120 to 139. Systolic diastolic 80 to 89. Stage 1, 140 to 159, 90 to 99, and more than 160 or more than 100 in diastolic blood pressure. Uncontrolled hypertension, blood pressure above the goal of more than 140/90 or 130/80 in patients of CKD-DM. Resistant hypertension, office blood pressure that remains above the goal. Patient prescribed 3 or more antihypertensive medications at optimal doses, including possible a diuretic or office blood pressure goal, but the patient requiring 4 or more antihypertensive medicines. So after giving 3 drugs, even 4 drugs, the treatment goal cannot be achieved, as considered as case of resistant hypertension. Now coming to epidemiological resistant hypertension, this is the Western data, largest data series in Spain, registry of more than 62,000 patients treated with hypertension. Prevalence is 12.2% of office BP measurement and 35% in tertiary care center. Now approach to the patient of resistant hypertension. Our approach first to exclude pseudo-resistance, then to identify and reverse the contributing lifestyle factors. Third, discontinue, reduce the interfering substances or different drugs. Then screen for secondary hypertension, lastly pharmacological treatment, and ultimate target is referral to hypertension specialist. The hypertension specialist term was used in is used in mostly in Western countries like USA. Now coming to pseudo-resistance. What is pseudo-resistance? Poor blood pressure measuring technique, poor adherence, white coat effect, poor BP measuring technique, including train your staff, average 2 readings 1 minute apart. After 5 minutes of the rest with back supported, use appropriate size staff. Common mistakes, measurement of BP without letting the patient at rest, too small cuff, because it is often found that a patient above weighing above 120 kilos, a very obese patient, but we are measuring the blood pressure with the cuff normally used in 60 kilo patients, but this may result false sense of hypertension, whereas the normal BP may be low. Actually, of his or her size cuff if may be used, then BP may be low, even normal. And less common, acute effect of cigarette smoking, acute effect of coughing. So just going to the doctor's clinic, patient may have a smoke or having a tea or coffee. Poor adherence, patterns of resistance of antihypertensive medicines in newly diagnosed patient, hypertensive patient. 1 year adherence. 1 year adherence, the continuous around 20%, combiners 22%, switchers, switch from a drug which was prescribed firstly, then switch to another drug, either as a self target or as a self goal or by advice of some other people, or maybe other and discontinuous. Discontinuous a very large number of 42%. Having a single visit for 1 year of treatment, 42% patient often discontinue. Factors leading to poor adherence, cost of the treatment, complexity of the treatment. For example, simple example, cost of the treatment. Patient may be given amlodipine. Amlodipine is very cheap, around 2 to 5 rupees a single tablet. But when we use instead of amlodipine, olmesartan 20 milligram tablet costing around 9 to 10 rupees, and 40 milligram tablets even at 16 to 17 rupees. So patient often switch from amlodipine from olmesartan to amlodipine after using 6 months or 8 months of continuous therapy of his own. Complexity of treatment. We are giving 3 or 4 antihypertensive drugs, but we are giving the drugs in such a way, one drug in the morning, one drug afternoon, one drug late afternoon, one drug in the evening, but we are not using combinations. So in that case, combination effect may be helpful to the patient. Coming to side effects, like amlodipine-induced pedal edema, one simple example, or AC inhibitor-induced dry cough. Instruction not understood. Organic vein syndrome like memory deficit, lack of consistent or continuous primary care. Now identify different hindering factors. The factors which may produce hindrance, like lifestyle factor, obesity, physical inactivity, excess alcohol consumption, high salt diet, low fiber diet. Now medications that can interfere with blood pressure control, like non-narcotic analgesics, NSAIDs, COX-2 inhibitors, acetaminophen, regular use of painkillers for osteoarthritis, most commonly seen in elderly population. Patients are taking diclofenac or acetaminophen tablets for years without any doctor's consultation, but he or she is having hypertension too. Use of glucocorticoids. Use of glucocorticoids in asthma and autoimmune disease condition. Use of alcohols. Use of stimulants like these methylphenidate, dextromethorphan, amphetamine, etc. or drug abuse. Cyclosporine and tacrolimus use, erythropoietin injection, and herbal compounds like Mitra or mahua. Now screen for secondary hypertension. Common obstructive sleep apnea. First reduce the hindrance factor, which may be causing difficulty in treating hypertension. Obstructive sleep apnea, chronic kidney, renal vascular hypertension, primary hypertension, and some uncommon factors like pheochromocytoma, Cushing syndrome, thyroid disease, primary hyperparathyroidism, aortic coarctation, or brain tumors. So we have to screen thoroughly. Patients may need multiple investigations also. Secondary causes of hypertension. Screening of secondary causes should be guided by clinical history, physical examination, initial laboratory testing, presence of risk factors. Current guidelines support referral for a specialist at this point even without initial screening. Now coming to this diagram, BP or high BP may be caused by different factors. First factor is autoregulation. Autoregulation, the drugs used to treat these autoregulation problems like calcium channel blocker, hydrolazine, minoxidil. Then comes to the salt and water retention, salt or water over intake or salt or water retention. This can be managed by diuretics. Humoral factor can be dealt with AC inhibitors, angiotensin 2 receptor blockers, direct renin inhibitors, mineralocorticoid receptor blockers, and sympathetic nervous system dealt with alpha blocker, beta blocker, and alpha 2 agonist. Common factors, dose may be too low, failure to initiate effective dose. Patient is taking telmisartan at 20 milligram a day, but patient is needing actually need of the day is to increase the dose up to 80 milligram a day. But patient is taking 20 milligram a day for a long period. His BP is not controlled. Inappropriate antihypertensive drug combinations. Here comes the combinations. Combinations of like AC inhibitors and ARBs. Inappropriate combination. Inappropriate combination of like patient having dyslipidemia and hyperuricemia. We are still using some angiotensin receptor blockers with hydrochlorothiazide. Failure to use diuretics when volume overload is present. Volume overload is there, patient is edematic, patient may have some degree of anasarca, but we are not using diuretics. Failure to use furosemide when the estimated GFR rate less than 40 milliliter per minute per meter square. Then comes to addition of spironolactone. The effect of spironolactone in case of resistant hypertension. Office and 24-hour ABPM at the beginning of the study. We can see the blood pressure level around 150, office BP, the diastolic blood pressure around 100, and 24-hour ABPM similarly around 150, 24-hour ABPM DBP around 100, around 80 or 85. But here the yellow is placebo and the blue is spironolactone. And after using the spironolactone for longer duration, we may see the reduction of blood pressure up to office blood pressure 40 millimeter of mercury, sharp drop, and in case of ABPM around same 13 or 14 millimeter of mercury after using spironolactone. Here the role of spironolactone is very important. Spironolactone and eplerenone both can be used in case of resistant hypertension whose renin activity is very high. The physiology of blood pressure. Physiology of blood pressure depends on two factors. Number one factor V and number two factor R. The dual volume and vasoconstriction connection of long-term BP control. BP control depends on the tissue blood flow, therefore delivery of nutrients, removal of metabolic products. This is very important to maintain BP. In case of volume, body sodium volume content. The body sodium volume content, when it is high, the treatment goal may be different in case of than that of the high plasma renin activity. R, the V and R, two factors are very important. BP and high plasma renin activity. Normal BP, when the PRA is accompanied by reciprocal changes in blood volume. Hypotension, the kidney failed to reduce PRA. Hypertension, kidney fails to reduce PRA in response to increased body salt. PRA could be already maximally suppressed. Low renin hypertension. So we have to diagnose the patient whether patient is having low renin hypertension or high renin hypertension. According to that, we have to block the renin angiotensin system. PRA is too high, not necessarily higher than normal for the concurrent body salt content, normal or high renin hypertension. Here comes the treatment plan. Treatment plan is BP controlled on 3 drugs, 3 or more, or BP controlled over more than 4 drugs. Step 1. What is the step 1? To reduce the drug of one anti-V and one anti-R. If BP, step 2, measure the PRA level. If the PRA level is very low, PRA level less than 0.65, there is no renin block. Anti-R may be a pressure effect. In that case, if we reduce the plasma renin activity further, that may be detrimental to the control of blood pressure. So avoid these drugs, ARBs and angiotensin receptor blockers, and aldosterone 2. Step 3, stop anti-R. Step 4, if BP is uncontrolled, add second anti-V drug. If plasma renin activity is more than 0.65 to up to 6.5, renin effectively blocked. Step 3, add anti-V drug. Step 4, BP is uncontrolled, test stopping anti-R drug. If PRA activity is very high, volume depletion may be present. In case of pheochromocytoma, we may see the high PRA activity, volume depletion may be present. Then stop anti-volume drug. Anti-volume drugs mean diuretics. Diuretics have no use in case of pheochromocytoma. Step 4, if BP is uncontrolled, add second anti-R drug. And lastly, if BP is controlled, test stopping anti-V if PRA is high, then anti-R if PRA is low. Then comes to the latest therapy, the device-based treatment of resistant hypertension. What are the devices? Devices may be the renal sympathetic denervation or baroreceptor sensitization, the carotid baroreceptor stimulation. The schematic presentation of catheter-based denervation of the sympathetic nervous system stimulating the kidney. Here we may implant the transducer on the renal artery. I'm going to discuss in detail. The treatment method uses novel implants device, light research system, CVRX INC, Minneapolis, Minnesota, that works electrical stimulation of the carotid sinus. A non-randomized prospective study where the number is more equal to 45 assess whether the POS therapy could safely lower blood pressure in patients with resistant hypertension. Then lastly, specialist referral. Whom to refer? When to refer? Indications of referral. Refer may appropriate to specialist, the hypertension specialist, to know the suspected secondary causes of hypertension. Refer the hypertension specialist if BP remains uncontrolled after 6 months of treatment. Referral to hypertension specialist improves the BP control over 50% in patients with resistant hypertension. Who are the specialists? Specialists may be from endocrinology field, maybe from cardiology field, and maybe even a neuromedicine. And the subject having specialized degree or diploma course, which is approved in USA. I'm going to discuss about United States perspective. USA, a specialized course of 2 years is there. After doing the course, a doctor can be called as hypertension specialist. The conclusion: uncontrolled hypertension is not synonymous with resistant hypertension. Exclusion of pseudo-resistance, implementation of lifestyle intervention, discontinuation of interfering substances are initial steps approaching the resistant hypertension. Workup for secondary causes of resistant hypertension should be reserved for patients with appropriate clinical uses. Referral hypertension specialist can help to improve BP control. Thank you.
Thank you, Dr. Ganguly, for your in-depth presentation on this topic. As I've seen you from your first day of pharmacology, you have this curiosity of going into this everything that you have presented.
Thank you, madam.
But and also attending or being a pillar along with Dr. Chandra in Arkopal medication, reconciliation, OPD experience they're gaining also helps to express many things. Sometimes it is difficult to stop OPD on any topic like that. So here also he has gone for I don't know how far we can assess PRA or we can depend on PRA. That's practical. Anyway, it was a nice presentation. So we're enlightened. Definitely after that.
Thank you.
So for practical purpose, I just sum up in one line. Resistant hypertension, we start it as resistant hypertension when at least 3 drugs with different mechanism of action, preferably a long-acting calcium channel like Arkopal, AC inhibitor or ARB, and a diuretic, preferably a thiazide like diuretic like chlorpheniramine with optimal doses. When it fails to control the blood pressure to reach the target level, then we start it as resistant hypertension. And to treat it, we must start with the treatment along with this treatment of sparkle. This is the key word for you. With a real, very nice presentation, in-depth presentation of Abhijit Ganguly. And may I request you, if you have any question, I'm not asking you, you have enough time during dinner time to ask me. Okay, thank you.
Thank you, sir. So, may I request our chairperson to please felicitate Dr. Abhijit Ganguly. I request now Dr. Arkopal, who is an assistant professor of MS MCH Patna. So he will deal upon antihypertensive drugs and clinical pharmacological review. So I think it will be a very interesting topic, especially at the days of clinical pharmacology. This is actually the emerging topic that ECG changes with antihypertensive therapy. Also, ECG marker or ECG changes which may indicate the change of hypertensive state. That also may be targeted by him. So, I will request Dr. Bandyopadhyay to start.
Thank you very much, sir. So, a very good evening to all the chairpersons and all the delegates present here. My name is Dr. Arkopal Bandyopadhyay. So, as many of you cannot understand the short form of my medical college, which I am currently working in, it is Netaji Subhas Medical College. It's a new medical college in the outskirts of Patna. So, I'm working as an assistant professor in Department of Pharmacology there. So, basically, my topic of today's discussion is antihypertensive drugs and ECG changes, a clinical pharmacological review. Thank you. So basically, I'll be covering a few topics, changes in ECG, and then what are the characteristic changes which occurs as a result of the disease process, as well as the ECG changes which are caused due to various drug-induced factors. So 2020 International Society of Hypertension Global Hypertension Practice Guidelines states that 12-lead ECG is recommended for routine follow-up of patients with hypertension. And they also mention very clearly that sensitivity of ECG to detect complications of cardiac complications like left ventricular hypertrophy is very, very limited. And it also doesn't give an exact timeline of performing ECG, which is a very simple investigation per se, a 12-lead ECG during the course of therapy of hypertension. So what are the causes of concern for patients of hypertension? As we know that hypertension-induced left ventricular hypertrophy is individually a risk factor for sudden cardiac death. And there are various mechanisms which are mediated by adverse changes in depolarization of the hypertrophic myocardium, and with increased left ventricular mass, there is significant symmetric increase in depolarization remodeling in the heart. So all these factors are a significant cause of concern. And mostly, if you can see that all types of ECG changes are present in the course of hypertension in a patient, and these are modifiable factors which can be altered by antihypertensive drugs. So the probable changes of ECG with antihypertensive drugs are broadly classified into QT changes, then electrolyte abnormalities induced changes, then AV blocks, and changes as a result of disease progression per se. So what are the QT changes which are taking place over time? So there are multifactorial mechanisms which are implicating QT changes like cardiac hypertrophy, then increasing the left ventricular mass, and there are changes in left ventricular depolarization states. So all these factors can lead to QT changes. And a very important point to note here is that hypertensive drug exhibits a varying modulation of QT interval despite having similar antihypertensive, that is BP reduction features, as well as antihypertrophy, that is left ventricular mass reduction. So even if a drug is having similar antihypertensive effect, it is not necessary that they may have similar modulation of QT. Some of the drugs can increase QT, some of the drugs can reduce QT, and some of the drugs may not have absolute effect on QT interval per se. That is what we will discuss in the subsequent slides. Now, coming to individual drug categories, this is a chart I have taken from a review article on ACE inhibitors or ARBs, or basically RAS blockers and QT. So, if you can see that the various commonly used RAS blockers like enarafil, irbesartan, losartan, renin inhibitor like arispirine, they are tried in randomized controlled trials over a duration of like minimum 4 weeks to around 2 to 3 years. And all of them have noted significant reduction in QT intervals. Basically, effect on QT, then corrected QT, as well as QT dispersion, that is maximum by minimum QT difference. So all these have shown beneficial effects in reducing the QT interval per se. And the patient group on which they were tested are like so patient group they were tested were on hypertensive patients, hypertensive and diabetes, as well as hypertensive with left ventricular hypertrophy patients. So ACE inhibitors and ARBs per se have reduced the QTs in most of the studies. Just expanding one of those studies, so a chronic enarafil treatment has shown significant reduction in blood pressure over a span of 8 weeks. But if you see the effect on left ventricular mass, they have shown reduction in left ventricular mass over a period of 1 year. And if you see the QT interval duration reduction, that is seen over a span of almost 3 years, more than 3 years. Whereas in another study, when amlodipine versus irbesartan was compared, both of them had decreased BP. Only irbesartan had decreased the QT interval over the duration of the time. And they had shown positive correlation between decreased blood pressure as well as decreased QT duration. Whereas amlodipine, on the other hand, did not show very beneficial effects on the QT intervals. Similarly, beta blockers and QT, beta blockers decrease the QT interval durations and they normalize the ventricular depolarization in a dose-dependent manner, with having limited effect on the left ventricular mass or blood pressure. So, some of the older literature which had shown very limited effect on the reduction of the left ventricular mass, left ventricular hypertrophy and or blood pressure, but newer beta blockers have shown reduction in left ventricular mass per se. And this meta-analysis, which was done by Fagard RH, had shown the regression of left ventricular mass was significantly less with beta blockers. That is, beta blockers as compared with the angiotensin receptor blockers or ARBs. But the difference was statistically significant. So beta blockers had shown less reduction in the left ventricular mass as compared to ARBs. Whereas if you see the calcium channel blockers and QT, both of them, the calcium channel blockers have shown reduction in both BP and LVH, but they did not show any beneficial effects on QT interval, that is corrected QT interval. And there was failure to reduce cardiac depolarization abnormalities. And overall beneficial efficacy was decreased by various counter-regulatory mechanisms in renal and cardiac ways. And the most probable mechanism which was told were baroreceptor reflex-induced mechanisms. And some of them, like furosemide, has also shown to trigger QT prolongation and arrhythmias in hypertensive patients. Now, diuretics, coming to diuretics, loop diuretics and thiazides, as we have very commonly seen that they are associated with hypokalemia, electrolytic abnormalities and subsequent QT prolongations. And these electrolyte abnormalities are seen mostly around 8 to 12% of the patients. And they are not very frequent. And potassium sparing diuretics, on the other hand, they showed reduction in QT, corrected QT intervals. And the combinations of ACEI, ARBs plus potassium sparing also had shown to reduce the QT intervals. Now, coming to the electrolytic abnormalities associated with the antihypertensive users, there are various electrolyte abnormalities which are seen. the potassium-induced changes, calcium-induced changes, and hypomagnesemia-induced changes. And we'll just see a case in the subsequent slides. So hyperkalemia in ACEIs and ARVs are usually associated with reduction in aldosterone secretion, which leads to impaired potassium excretion. And as a result, the hyperkalemia is caused, and potassium sparing diuretics can also cause hyperkalemia. The concomitant comorbid conditions like CKDs. Okay, sir. Yeah, I have 2-3 slides here. So comorbid conditions are like CKD can also precipitate, and concomitant medications like NSAIDs can also be hamper this process. And the very common ECG changes are given in this picture. Now coming to a case, that is a 80-year-old diabetic hypertensive patient with stage 3 CKD presented with myalgia and weakness. Okay, and the patient was on linagliptin, telmisartan, metformin, and atorvastatin. As we can clearly see that tall peak T waves, which are characteristics of hyperkalemia in this patient. Now coming to the hypokalemia, on the other hand, they show flattening of the T waves and presence of the U wave in the ECGs, and this can be clearly seen in this with classical ST depression, as it can be seen in this image. Now coming to a case, just to iterate the same concept, that 74-year-old diabetic patient, diabetic and hypertensive, had one episode of blackout, and this patient was treated with torsemide among the others, and he has a history of recent history of taking moxifloxacin. And if you can see the ECG closely, then we can see that again the classic hypokalemia induced features of ST segment depression, and here we can see QT prolongation, as we know that moxifloxacin and levocetirizine both have the propensity to increase QT interval, and in this case we can see a prolonged QT in this patient. Now coming to the last few points of drugs that can exacerbate sinus bradycardia or AV block, as we know that alpha-2 agonists like clonidine has an incidence of around 5 to 17%, whereas beta blockers have in various studies reported 0.5 to 0.6 to 25% incidence of causing AV blocks. Now finally, to sum up all the results, what are the key take-home points? Long-term use of antihypertensives may be associated with ECG changes, and all the clinicians who are prescribing these drugs over a long span of time should be careful of these ECG changes. And frequency of ECG monitoring is a very debatable issue, and it is not very clearly given in all the guidelines, be it the national and international guidelines. The frequency of ECG monitoring over the time and over the treatment course needs to be clearly mentioned. And as far as we are concerned, a healthy symptomatic patient, asymptomatic patient or antihypertensive should at least get an ECG checked in yearly or in 2 years, whereas a symptomatic patient with end organ damage needs more frequent ECG checkup, and maybe in 3 to 6 months. And obviously the electrolyte abnormalities associated with all these drugs needs to be considered. So that's it for my presentation. Thank you very much.
Thank you, Dr. Mondal, for enlightening a really nice topic in front of us.
Thank you,
If you have any questions, we can discuss in the given time, because we really like 40 minutes behind the work today. Just one question I'd like to ask you: that is there any data regarding this common antihypertensive that we use, like the calcium channel blockers or the beta blockers, and what kind of ECG changes they have brought, or we have to withdraw? How many drugs we have to withdraw?
Yes, sir. Actually, yes, sir, exactly. I was also searching the same thing which you had asked, but there are no very clear guidelines on how what will happen when ECG changes occur in a drug, and how they will be modified, and how they will be. Right, sir. Right, sir.
So how are you able to really track those things and try to intervene and
right,
take
sir.
some automated treatment protocol?
Yes, sir. And
no, sir.
No, sir. There are very limited data, and most of the data is of Western countries, and they are of early 90s and 2000s. And only few recent studies are there on this QT interval prolongation with antihypertensive drugs. Most of the other drugs, they are not very clearly elucidated, sir.
Thank you.
Thank you.
Yes, nice presentation, Dr. Mondal. One thing that roughly organizational think of regarding the monitoring of ECG.
Yes, sir.
In the replacement of urinary hypertension. There is some studies now going on. So I was going through one video that ECG changes may be considered as hypertension or blood pressure measure.
Definitely, sir.
You will think of another topic.
Yes, sir.
Thank you, sir.
Thank you so much.
Thank you, sir. Thank you. Now, may I request our chairperson to please felicitate Dr. Arkopal. Appreciate. Thank you.
You know, the hypertension is treated by drugs. So there are some drugs which produces hypertension. That is again a problem for the clinicians and the therapeutics to take care of. So our speaker will take care of that. And one thing I should definitely highlight, especially in antihypertensive therapy for a long time, suddenly forgets to take the drug. So what happens, particularly the drug is a beta blocker. So what happens, if the drug is clonidine, of course the clonidine has a restricted use nowadays. So beta blocker is rapidly used for many cardiac diseases. Suddenly the person forgets to take the drug. And that creates a condition for rebound hypertension. So that has to be taken into consideration for the drug-induced hypertension that way. We have our learned speaker today, that introduce the speaker and the
Our esteemed speaker is Dr. Tanuka Mondal. She is a faculty in the Department of Medicine at Kolkata College. And she was an associate editor of Lackmaster textbook of Internal Medicine. And she won the first prize in the best case report competition in RCIN Poland 2021. And she is a sub-editor of JIMA, co-authors of multiple reputed journals, and speaker in multiple national and international conferences. Now, over to you, Dr. Tanuka.
So good evening to everyone present here to make the National Symposium on Hypertension Management organized by Indian Pharmacological Society, West Bengal chapter, such a huge success. And I would also like to thank my respected chairpersons who have given me such a wonderful introduction. With that, I would like to start my talk on management approach considerations in drug-induced hypertension. So just to introduce, hypertension is directly responsible for 57% of the stroke deaths and 24% of coronary heart diseases in India itself. And we all know that hypertension is one of the most dreaded comorbidities that we face in our as a clinicians in our day-to-day practices. And so it is this kind of huge death is responsible for hypertension. So we must be very, very careful while prescribing medications which may even cause hypertension. So although we have known that most cases of hypertension are idiopathic, that is essential hypertension, but among the secondary causes of hypertension, we have to know that drug-induced hypertension plays a very important role. And hypertension may become even difficult to control due to the concomitant drugs or supplements or herbal products or even any other substance that may be ingested, co-ingested by the patient, even with or without our knowledge. So a history, taking up a history is very important in these patients. As we move on to the next slide, I would like to discuss regarding three mechanisms today. So the first mechanism for drug-induced hypertension for me will be volume retention. We can see volume retention in three types of drugs. One is NSAIDs, the next one is sex hormones, and the third one is corticosteroids. Now with NSAIDs, as NSAIDs inhibit the COX-1 and 2 enzymes, it decreases the prostaglandin synthesis. Now PGE2 and I2 vasodilate and excrete sodium from our kidneys, thereby decreasing our blood pressure. But when we give NSAIDs, it decreases their production, and thereby there is increased sodium sodium reuptake in our body, and there is also vasoconstriction. It fails, the PGE2 and the PGI2 fails to vasodilate, and thereby decrease the pressure. So thereby the pressure is increased when we give or prescribe NSAIDs to patients. As we can see that of all the drugs, BP elevation of almost 6.2 millimeters mercury was seen in piroxicam. But similarly, as we can see that for common drugs that we prescribe, diclofenac has one of the least BP elevating factors. So of all the drugs that we prescribe for NSAID, that is usually we prescribe it in pain, on chronic pain, or in any kind of pain, I would say that diclofenac would be a better choice than any other drug. It must be also remembered that indomethacin that we give, or even an ibuprofen we give in our regular day-to-day practice, it also increases the BP substantially and may hinder the well control of hypertension in our patients in our day-to-day practice. Next, let's move on to the next drug, that is the sex hormones. We commonly prescribe, even females, we commonly prescribe OCPs in our day-to-day practice for the regulation of the menstrual cycle, for dysmenorrhea, and for many other things. But it is to be noted that this kind of drugs increase the angiotensin synthesis in our liver, thereby increasing the angiotensin too. And thus this increases the aldosterone secretion, which activates the mineralocorticoid receptors and cause sodium absorption and water retention. Thus, when we prescribe this kind of drugs, we should be very aware of what is their basal blood pressure. And we should always take care to regularly monitor this blood pressure of such kind of patients, because we don't want to treat one disease at the expense of the other, creating another one. We have to be very careful. Next, let's move on to testosterone. Now, testosterone is taken mainly in bodybuilders nowadays, and it is and it's also seen to increase the blood pressure by acting on the androgen receptor agonism. So it leads to the activation of the androgen receptors, causing an increase in the sodium and the water retention, thereby increasing blood pressure. Next is corticosteroids. As I think each and every person in this room knows that corticosteroid is notorious for increasing blood pressure. When we separate it in the two ways, that is the mineralocorticoids and the glucocorticoids, the mineralocorticoids usually cause sodium retention, and the glucocorticoids mainly fluid retention. Now, the mineralocorticoids that we usually use in our day-to-day practice is aldosterone and fludrocortisone, and it is very much prescribed just like the glucocorticoids for our day-to-day clinical practice, like in patients with COPD, in patients suffering from SLE. We give methylprednisolone, hydrocortisone, prednisolone in our daily practices. But just like the previous slide that I had shown you, and I told you that regular BP monitoring is a very essential part. Here also we should consider the basal blood pressure, and we should regularly check it, so that not to create any such kind of adverse effects like stroke or CVD because of not checking or forgetting about that we have put the patient on corticosteroids and blood pressure is not regularly measured. Now let's talk about the management of such kind of drugs which cause volume retention. So actually the three drugs that I've said, each works in their exact different pathways. So first we have to consider, is really the drug essential? Is really giving a pain medication essential for this patient? Or any kind of other medications may be prescribed? And another thing, if really the drug is required, we should put the patient in the lowest dose possible. Do not give excessive medications. And also the shortest duration for this medication is to be prescribed. Just like if there is an acute pain or acute condition, just treat it for that time till the patient requires the drug. And as I have shown in the first slide, as I had said, that diclofenac has less BP, it causes less increase in the blood pressure. Such kind of drugs should be preferred than ibuprofen if the condition supports, only if the condition supports. It may become necessary to add medications to minimize the volume retention effects also. like hydrochlorothiazide may be added or chlorothiazide may be added in this kind of patients. So now, as I said regarding volume retention, I'll go to the next one, that is sympathomimetic actions. Now, sympathomimetic action, the drugs that work by this mechanism of action, is one of the most commonly used. Each and everyone in this room has definitely used in some part of their life, is the decongestants. Now, of decongestants, I will talk regarding phenylephrine and pseudoephedrine. These drugs act by stimulation of the alpha-1 adrenergic receptors, and they increase the blood pressure of the patients. This taken for a long time, especially this kind of decongestants taken for a long duration, like our patients try to use it, may cause hypertension, increased blood pressure, not hypertension, but it will cause a lack of controlling of the blood pressure. In caffeine, patients seen the caffeine intakers, means those who take caffeine for long duration, it has been seen that there is not much effect, but as soon as we take a cup of tea, within 15 to 20 minutes, our blood pressure shoots up by 5 to 6 millimeter mercury. And it stays like that for 3 hours. So if a patient, just like I think our previous speaker told, that while finding for resistant hypertension, we have to also keep in mind that whether the patient had taken a cup of tea or maybe a cup of coffee before attending our clinic. So how does it act? It acts by increasing the catecholamine release and antagonizing the endogenous adenosine. That is how caffeine increases our blood pressure. Now, cocaine. It is not so much, I think it's not so much seen in our day-to-day practice, but it is a very notorious drug, and each and everyone, I think, if any one of you is asked regarding 2 drugs, name 2 drugs which causes hypertension, the first 2 things that will come in mind is cocaine, and the next one is corticosteroids, of course, which I've already covered. So how does cocaine act? It acts by preventing the peripheral reuptake of norepinephrine and leaving the neurotransmitter in the synapse to excessively stimulate the adrenergic receptors. It causes an increase of blood pressure by almost 15 millimeters of mercury, and it is seen to affect continuously in those patients who are taking, patients addicted to cocaine. Next, we come to the psychostimulants. Kids, children who are affected with ADHD or attention deficit hyperactive disorders, they have been seen to be put on psychostimulants like methylphenidate and like dextroamphetamine. This kind of drugs acts by increasing the amount of norepinephrine in the presynaptic nerve terminals, causing adrenergic activation and vasoconstriction. So it has been seen that the blood pressure, especially in the diastolic blood pressure in these children, is increased by almost 3.9 millimeters of mercury. And in case when this kind of drugs are advised for adults, it is seen that both the systolic and the diastolic blood pressure increases. In children, only the diastolic blood pressure is seen to be increased. So this kind of the children with ADHD, they need to be given on psychostimulants, and the dose cannot be reduced. So in these patients, again, we have to be very, very careful while prescribing such drugs, and constant monitoring is required for this kind of patients. Now, antidepressants, we use this drug almost in my practice. I have to use this, and we get patients who need TCA and SNRIs. Of this, they both act by increasing the norepinephrine and sympathetic activity. Of this, I would like to say that venlafaxine has been shown to cause a dose-related increase in blood pressure. As we increase the dose, so does the increase in blood pressure occur. Bupropion is another common antidepressant that we have seen to have shown increase in blood pressure, especially through the dopaminergic pathways. So this kind of drugs, which we again prescribe in our day-to-day practice, needs careful monitoring. So finally, next we go on to how to exactly manage this kind of, for managing this kind of patients on drugs for which act through sympathomimetic activation. First, we have to limit the exposure. As much as needed, so must be given. Do not prescribe the patients. Patients should be educated that only using the nasal decongestants, as I've said previously, for the least amount of time possible. most of the patients that I have seen, such patients that who have nasal, once they get this nasal decongestion, they use it for long times. They, even if we advise them, they will say that it feels good. Doctor babu bhalo lage, thik thaki amra. Keno apni baron korchen? So we have to educate this kind of patients. And we, of course, we have to monitor them, and we have to educate. The first thing will be limit exposure and educate patients. Next, hypertensive patients who are drinking caffeinated drinks should be advised to drink less such kind of beverages, and they should also be educated. In cocaine addiction, nitroglycerin, nitroprusside, and intravenous phenethylamine may be used to bring this blood pressure down. You have to remember, in this kind of patients, please do not prescribe beta blockers. This will only help the alpha receptors to, there has been no blockage for the alpha receptors to work, and thereby only beta blocking will further increase the blood pressure in this kind of patients. Next, guanfacine alpha-2 agonist is a medication that is commonly added to the treatment of this ADHD patients. As I've said, that we can decrease the medication in the ADHD patients who need the medications for their proper activities, especially in children. You can't stop it. So this, yes. Okay, I'll be just another way, another mechanism. Thank you, ma'am, for reminding me. Thank you so much. So the last mechanism, I'll just finish it off in a hurry, as madam has said. So it works by vasoconstriction, and we have two drugs, calcineurin inhibitors and VEGF inhibitors. Of this, the calcineurin inhibitors, cyclosporin and tacrolimus is there. It acts by reducing the amount of nitric oxide production and the systemic and renal vasoconstriction, as well as sodium retention in the kidneys. These are the mechanisms by which it acts. The VEGF inhibitors, they have the most important side effect of causing hypertension, and the drugs that are commonly prescribed, I have mentioned there, I'll not go through it. Now, bevacizumab, monoclonal antibody, which has been used in breast cancer and in colon cancer. It has been seen to cause hypertension greater than even 180 by 110 millimeters of mercury in 23% of patients in a study that has been done. So in this kind of patients, there is severe risks associated with rejection, so we cannot discontinue the immunosuppressive agents. These are all immunosuppressive therapy, and we cannot discontinue that. So the lowest dose is preferred in these patients. And the calcium blockers and ACEIs are the first-line antihypertensives in these patients with calcineurin-induced hypertension in cardiac transplant patients, especially. VEGF inhibitors I also use in the treatment of certain types of cancers, and discontinuing them is also not preferred. So it is advisable to reach the blood pressure goal before initiation of VEGF inhibitors. I'll just, this is the table. I think it's not visible properly, but this is the table which has the entire thing that I have been saying so long. The entire thing is written over here. And so in case of the management, when we have to evaluate the appropriate BP therapy if treated, and I'll just, it shows that whenever we get a patient of this kind, we have to evaluate the concomitant drug or the drug-related causes which may cause the increased hypertension, and we have to evaluate the BP therapy. If the evaluation of the concomitant related drugs are present, we have to find the drugs which are offending. Next, we have to evaluate the risk versus the benefits of the offending drug, and we can discontinue the offending drug, and if possible. And if evaluate the appropriate BP therapy, the therapy that is going on, if it is being treated, we have to understand it, and if there is any drug-related causes or not. If we continue that therapy, if there is the risk-benefit therapy of any offending drug, if we have to continue the drug, first we have to understand that by which of the mechanisms it works, whether by volume overload, by sympathomimetic action, or by direct vasoconstriction. If by direct vasoconstriction, we can give CCBs and ACEIs, as I had said, with calcineurin inhibitors. If it is by sympathomimetic activity, we can limit or optimize the current antihypertensive regimen, or add first-line therapies like ACEIs or ARBs. And if there is by volume overload, we can consider diuretic therapy, or for sex hormones, add ACEIs or ARBs, and for NSAIDs, consider CCBs or centrally acting antihypertensive, and for corticosteroids, ACEIs or ARBs. So with that, I will like to say that, my take-home message on the last slide, I'm just there, madam, I'm just finishing off. So the polypharmacy is very common and it contributes to the secondary causes of hypertension. And so optimal management of the drug-induced hypertension by discontinuation or minimization of the offending agent is suggested. And for most causes, drug-induced hypertension, optimal antihypertensive is still unknown. We have shown that there are multiple antihypertensive, not a single one. And understanding the mechanism of drug-induced hypertension may only allow us to use a more rational selection of antihypertensive therapy. Thank you so much for giving me that extra time. Thank you so much, lovely audience.
Thank you for your beautiful explanation of this is one part to take care of. Second, there is an explosion of drug development after the Second World War. We are getting every day more antihypertensive, more hypertension. So for that matter, the clinicians or the community be very aware about how less amount of drug we give to patients. Another rightly you told that there is no drug more yet to treat the drug-induced hypertension. So it is the titration of dosage and the restriction of prescription. That's another thing. Now, thank you very much again. Is there any question from the audience or thank you very much.
Just one question. As
Yes.
you have said that OCP
Yes.
regulate almost
Yes.
regulate
Yes.
So what is your idea? Let's say there should be 6 months of continuation, then they should stop it for another 3-4 months, and again it is beneficial. Or say ideally if they're not going to use it, that is an ideal situation. But it is not happening. Even the young people who are getting newly married, they used to come even having a first baby because she didn't want to have a pregnancy rival. So what is your suggestion?
Yeah, actually, my suggestion will be that if there is the reason behind giving an OCP should be seen, basal blood pressure should be seen, and asking her to use barium methods or any other method that may be for that contraception. And if for any other reason it is used and it is mandatory, then we have to see that we have to regularly check whether she's becoming hypertensive or not. I will prefer those. No, we should not discontinue. The discontinuation depends upon the cause. What is the cause behind giving the OCPs? Which is a gynecological problem. It should be dealt and it should be stopped, or it should be continued.
Already, you do some paucity of time.
Yeah, sure.
Yeah.
Save
the time. Thank you very much.
Oh, thank you so much. Thank you.
Thank you, sir. So now we request our chairpersons, Professor Krishna Puri, sir, and Dr. Shambo, madam, to felicitate Dr. Tanuka Mondal with a certificate of appreciation. On the work, sir, who needs no introduction. So please, sir, you have to share the session. Fortunately, I am the speaker.
So good evening, everybody. And, we are really running short of time. And actually, Shambo, I don't think he needs any introduction now. And when we decided to elect our new executive committee, and I hope by the time, by this time, we have all realized that perhaps he was the right choice, maybe. So definitely he was the right choice, and he has been doing an excellent job.
and making continuously online programs in different ways and now he has come out and he is able to organize these kinds of symposiums and please will you give a applaud and big hand to some to be more and more enthusiastic to continue with these things. So with these few introductory words, the summary delivers the 24-hour control. Choice of the right drug.
Thank you, sir. It is really a privilege for me to speak when my teacher and even sir was my principal when I was in Arkopal Medical College, and I always get his guidance. So we are talking about now 24-hour BP control and choice of right drug. So right means, this word right is very controversial because when I am taking right, my right hand, who is sitting in front of me, they are seeing my right hand in their left side. And we always believe, or some medication safety announcements like that, we need to follow 5 rights: the right patient, the right drug, the right dose, the right route, and the right time. But it was also mentioned, this type of 5 rights in medication safety, this is, if we just say these 5 words, this is just like a travel without a map. So we need to very cautious, we need to holistic while choosing the word right. I will try to emphasize few areas where we need to give extra monitoring to select some drugs which can act 24 hours. So this is one 56-year male who is diabetic and hypertensive on sitagliptin 100 mg, metformin 2 gram, losartan 100 mg once daily, cilnidipine 20 mg once daily, atorvastatin 10 mg. So current HbA1c is 6.9%, creatinine is 1.4, urine albumin creatinine ratio is 245. So in the microalbuminuria range, the eGFR is 59. The BP is at clinic BP or office BP is 140/78. So now he was advised to do one ABPM, ambulatory blood pressure monitor. Now you can see the result of ABPM. So when the patient had visited at around 9 p.m. to the clinic, so that time we found the BP was around 140/78. But as we advised ABPM, so there are lots of issues you can see here. So this is the x-axis, you can see the time duration, different time points. And now if we just see the dipping, and that is at around night, the dipping is well, and the BP is well controlled here. But what happened in the morning time, and even after that afternoon or evening period, this area, the BP was elevated. And it was also short at what time the patient is taking antihypertensive drug. So the BP lowering medicine he was taking at around 7 p.m. after returning from the office. That means losartan and cilnidipine. So you can see then the results of that. Now what to do, we will discuss later, but we need to appreciate that India or this South Asian zone is now becoming a capital of different types of metabolic disorders, and hypertension is one part. So we need to appreciate well that we are more salt sensitive. Our obesity is little bit different than our Caucasian friends. We are going to move in the very recently in India will maybe within 25 years we will become the diabetes capital. Metabolic syndrome is another important issue, and our lifestyle change. Seasonal variation is again important. The seasonal variation means when we are checking blood pressure in the winter session. So in winter, there is insulin resistance that appears, and that causes increase in blood pressure. Air pollution, again, a very important concern here. And you can see the PM 2.5 concentration or more that causes insulin resistance and related hypertension and other metabolic complications. Dietary habits are changing, urbanization is happening, and also we are suffering from blood pressure variability. And this diagram we can see why we need to address the blood pressure, because we see there already we have different types of chronic risk factors, but when the chronic risk factors is there, on top of chronic risk factors, if there is more acute risk factors like exercise, mental stress, strain, smoking, or air pollution like things that happen, that causes high rise, surge in the blood pressure. And the variability we can find that even the seasonal variation to day by day variation to diurnal variation, the mostly affected by this trigger specific surge. So we already are exposed to those chronic risk factors like salt, obesity, or metabolic syndromes like that. CKD, more we have are in position to develop more CKD or diabetes. On top of that, if we are exposed to different acute risk factors, then there will be more changes happen in our blood pressure, and we need to address. And to target that, there is two parts when we are treating hypertension, and that we are talking about 24-hour control. We should target our morning blood pressure below 130/80, and also we need to first find whether there is some nocturnal hypertension or not, and then we need to target that mast uncontrolled nocturnal hypertension with some medications. And generally the dictum is the nighttime home blood pressure that should be below 110/65 millimeter of mercury to achieve the perfect cardiovascular risk reduction. And for that we need to address such issues like obstructive sleep apnea, insomnia, different other vascular disease like atherosclerosis, and if the patient already have high circulating volume. So as we are talking about 24-hour blood pressure control, that means we should have a strict 24-hour BP control. That means the average should be less than 130/80 as per the ACC/AHA guideline. Then we need to address the blood pressure variability. That means morning blood pressure surge that should be below the 19th percentile from that ABPM report. And the circadian rhythm, mostly we should focus on that nocturnal hypertension, and we should have a 10 to 20% fall in the nocturnal blood pressure to have that ideal dipping time. And why this 24 blood pressure control is important? Because with every 10/5 millimeter increase in 24-hour SPP/DPP, that increase the combined risk of cardiovascular mortality, ischemic heart disease, and stroke by 35% in case of home BP monitoring, that is 24-hour SBP, that means ABPM report. Whereas just if we consider the office BP, it is 18%. So we need some tool to understand the ambulatory blood pressure. And even if we just check the diastolic blood pressure data, they also suggesting the importance of home blood pressure monitoring. So to have a 24-hour blood pressure control, we need to select a drug which obviously should have a long T-hub. And we know if we consider different group of antihypertensive drugs, which are the drugs which have longer T-hub. We have in the ARBs the telmisartan, which is a long-acting drug, 24 hours, olmesartan, 13 hours. If we consider the diuretics, again the clothalidone, which is a long-acting 40-hour half-life. With indapamide, it is 14 to 18 hours. Whereas the hydrochlorothiazide has a variable half-life. If we consider different SC inhibitor, then also the perindopril has the longest half-life, along with enalapril has around 11-hour half-life. If we consider beta blockers, the nebivolol has a long half-life, along with bisoprolol, which has a 12-hour half-life. And that is why we always use metoprolol as an extended release form, because of its shorter half-life of 3 to 7 hours. But when we are talking about calcium channel blockers, the amlodipine has a longest half-life, we can see, almost 30 to 55 hours. So to reach the 24-hour blood pressure control, if we consider a long half-life, then from the calcium channel blocker, we can consider amlodipine. From AC inhibitor, we can consider perindopril. From ARB, we can consider the telmisartan, and from chlorthalidone, we can consider from the diuretic group. Now, another concept is very important, that trough by peak ratio. So what is trough by peak ratio? That means when we are using some drug on top of placebo, when we are giving that particular drug, so at that time, we are assuming the effect of that particular drug is minimum. So we are taking the blood pressure reduction capability at that time, that trough time, and then we need to check the maximum capacity of that particular drug to reduce the blood pressure from the baseline or placebo, and that is the peak. So in this case, you can see this drug B, the trough BP reduction is at around 4 millimeter, when the peak BP reduction, that is around 10 millimeter. So if we just consider the ratio, it is 45%. But as drug A concerned, you can see there is the peak BP reduction is 5 millimeter of mercury, whereas the trough BP reduction is 4 millimeter of mercury. So though the overall blood pressure reduction is much lower in drug A, but the trough by peak ratio is better, or rather at around 75% in favor of drug A compared to drug B. So as per the FDA, they mentioned like that, if a trough by peak, if for a drug, if the trough by peak ratio is less than 50%, so that should not be considered as a once daily drug. So when we can, if we just consider trough by peak ratio of different drugs, then also we will find that in ARBs, the agilcertan has almost 97% trough by peak ratio, whereas the telmisartan also have 90% trough by peak ratio. And in case of losartan, it is little bit lower, and it is 70%. When we are talking about diuretics, the trough by peak ratio of hydrochlorothiazide is variable between 60 to 92%, whereas indapamide is 55%. And in AC inhibitor, again the perindopril, that is around more than 75%, and we can consider perindopril as a true once daily drug as per the trough by peak ratio issues. Regarding the beta blockers, again the nebivolol has the highest trough by peak ratio, whereas the bisoprolol also has more than 50%, that is 58% trough by peak ratio, and carfentanil has 75% trough by peak ratio. Now coming among the calcium channel blockers, the amlodipine has highest trough by peak ratio, and that is 100%. So candesartan, telmisartan, perindopril, amlodipine, nebivolol, they have highest trough by peak ratio. Then another important factor that needs to understand, that is smoothness index. So what is smoothness index? Smoothness index means if we measuring blood pressure for 24 hours, then each hour the blood pressure reduction we need to take care. We need to have an average blood pressure reduction. Then that delta blood pressure reduction, average of that delta blood pressure reduction divided by the standard deviation, that is considered as smoothness index. And this also gives us some information about that homogeneity of 24-hour blood pressure reduction. Generally, smoothness index more than 1 is most desirable, and that indicates a large and consistent blood pressure reduction. And if we consider different antihypertensive drugs and their smoothness index, then we will find that telmisartan and amlodipine have very near to 1 smoothness index. So higher smoothness index, that indicates smoother 24-hour blood pressure reduction. Then we need to talk about something regarding that early morning BP surge, because why it is important? Because if the blood pressure, morning blood pressure is more than 135 by 85 millimeter of mercury, regardless of an individual's office BP values, that increase the chance of associated different types of cardiovascular events. And which is very important to note that we Asians have more chance to get different types of cardiovascular events if we have early morning BP surge. And that is why I think our ancestors told us to wake up at around 4 a.m. and to do something called pranayama or yoga to control our sympathetic nervous system hyperactivity and to get rid of this type of atrocities. So early morning surge, that was from a honest study, we will found when morning SVP is more than 145 millimeter of mercury, then the cardiovascular risk increased almost 2.47 fold, even if the office SVP is less than 130, and 3.92 fold, so almost 4-fold increase if the office SVP is more. So not only considering the office SVP, we need to consider ambulatory blood pressure monitoring and this early morning surge. And these are the stepwise approach by which we can control the early morning surge. And another issue, that is nocturnal hypertension. So what is nocturnal hypertension? Now it is almost more than 9. So if anybody of us having blood pressure more than 120 by 70 millimeter of mercury, then we can be stamped as nocturnal hypertension. And this is again very important because many patients who are presented with this masked nocturnal hypertension, they had more chance to develop different type of cardiovascular disease. And we can see the increase in intima medial thickness and relative wall thickness of 19 and 22% versus normotensive. That means who are nocturnal normotensive. And there are lots of studies which suggest that means the dipping means what is normal dipping if it is between 10 to 20%. So that is the dippers, the ideal situation. But who are non-dippers and risers, there is more chance to have a damage in brain, heart and kidney, and also the future cardiovascular events. So we need to address this nocturnal BP management by sodium restriction, potassium supplementation, again use of long-acting drug, because there is a tendency of us to take the antihypertensive drug in morning. But there are studies which suggest if we take the antihypertensive drug in night time, that will also take care of this nocturnal hypertension along with the early morning BP surge. And the treatment of sleep apnea, again, that is a hidden epidemic, we must say, because of rising obesity in our country, the sleep apnea numbers are going up and up. So what are the benefits of long-acting antihypertensive drugs? These are different aspects of giving long-acting drugs. If it is a high half-life, that will give some gradual onset and slower offset of action, a consequent longer duration of action, greater therapeutic coverage, and also once daily drugs means that will increase the adherence. So now coming to the case that we had started, that this patient who has ambulatory blood pressure monitoring results like this. So we need something which can cover the 24-hour blood pressure. So what we did, I think there is no time to take the response from our learned audience. So what we did, we give telmisartan 80 milligram instead of losartan 100 milligram. We had started amlodipine 5 milligram once daily instead of cilnidipine 10 milligram. And also we had added dapagliflozin. That is again a separate issue. Why we added dapagliflozin, that can be discussed further because of that urinary albumin creatinine ratio. Also, there are studies which suggest SGLT2 inhibitor has a very good action in tackling that nocturnal hypertension. So with that, I want to thank you all again. This diagram is very important because light and life 2L is very important for all of us, and we need to follow this rhythm, this circadian rhythm. as I am very sorry to all of you, because due to this meeting, we had crossed almost 9:30, and it will be almost 10 when we are going to finish today's meeting. So this type of meetings actually hampers the rhythm of light, that means circadian rhythm. So we need to take care of this rhythm of this rhythm to get a healthy life. With that, I thank you all again. Thank you.
Thank you, Shambo, for your excellent presentation and how to control 24-hour control of blood pressure. Pharmacotherapy control, of course, besides pharmacotherapy control, there are certain other means and aids nowadays available, particularly the term which is very much used nowadays, the lifestyle modification. There is a very important part of control of hypertension. Not only hypertension, because we all know that these diseases, particularly in Southeast Asia countries, is becoming epidemic almost, these kinds of things. So we will not discuss in detail, because as he has already told something about circadian rhythm, which is being already altered, and I do not know whether all of us be elaborate for that. That is another debatable question. However, I will not allow any question because there is a real shortage of time. However, at the end, we had an excellent program at that. We said with these few words, I thank you again, Shambo, for your presentation.
Thank you.
I have not noticed whose signature is there. Unfortunately, it is mine. So I am giving my.
Now we are moving over to our next session, and to chair this session, may I request Professor Rohan Tripathi sir to please come up to the dais.
Now, we are requesting Ghosh. To be someone Pharmacovigilance with Antihypertensive therapy. Abhishek, তুমি কোথায় আছো এখন? Please give your introduction.
College of Medicine, JNM, Kolkata.
Which course?
Assistant Professor.
Assistant Professor. Okay, very good.
So good evening, learned audience. Actually, all are my senior teachers, and this session is shared by Professor Rohan Tripathi, who is actually going. Actually, he was the professor in our medical college days during my undergraduate training, and I'm seeing many teachers who are during my postgraduate teacher training. So respected teachers, so I am going to highlight another aspect of the antihypertensive therapy. So all we have asked so far is actually the control of the blood pressure, but our aim of therapy is not only blood pressure control but also avoid some harms, because our primary goal of any kind of pharmacotherapy is not to harm any patient, but unintentionally definitely sometimes some adverse effects happen, and that's we have to monitor and we have to report it so that these unwanted situations can be prevented better.
So I am discussing about the pharmacovigilance with antihypertensive therapy. So pharmacovigilance, I think it's no more discussion with the learned audience. So it is the science and activities relating to the detection, assessment, understanding, and prevention of the adverse effect or any other medicine and vaccine related problem. And adverse drug reaction is a response to a drug which is noxious and unintended and which occurs at doses normally used in human being for the prophylaxis, diagnosis, or therapy of the disease, or for the modification of the physiological function. So it happens in the normal dose. And ADRs are considered among the leading cause of morbidity and mortality. And if we think about the global data, that around 6% of the hospital admission are estimated to be due to adverse drug reaction, and about 6 to 15% of the hospitalized patient experience a serious adverse drug reaction. So these are the types of adverse drug reaction: augmented, that means it is dose dependent. Example, hypoglycemia due to insulin overdose. And type of effect is that B is bizarre, that is unpredictable, and often it's fatal. It is not dose dependent. Example, anaphylaxis to penicillin. C is chronic, that adverse event occurs after prolonged treatment, and delayed means that can happen after years of the treatment. So this is the causality assessment scale. I am not going to detail. It shows how likely the drug is going to cause that adverse effect. So pharmacovigilance basic concept is that it is an umbrella term used to describe the process of monitoring and evaluating ADRs. So monitoring of ADRs requires these steps: detecting of ADRs, documentation, reporting serious ADRs to pharmacovigilance centers that is present in all pharmacology department of medical colleges, and assessing causality between drug and suspected reaction. So it is very much important. So because not only we have to report the adverse reaction, but also it provides data about the treatment failure. It provides insight about the counterfeit and poor quality medicines. It can provide insights about regarding drug interactions which patient is taking already, apart from their antihypertensive medication, and incorrect use of the medicine. Generate evidence that will inspire the public confidence and trust. And why it is important to monitor the ADR in hypertension? Because it is a long-term therapy, probably lifelong therapy in most of the patients. It predisposes to more adverse effects. And hypertensive patients often have comorbid conditions. That's why they are already on multiple medicines like antidiabetic and medicines for hypothyroidism, medicines for hyperuricemia, dyslipidemia, etc. And that predisposes to cardiovascular risk and mortality. And medicines may add on because hypertension control may be poor with the continuation of the single agent. So that's why drug interaction risk is actually increasing as the years pass on. So antihypertensive groups and their specific adverse effects, what are the different studies says. So classification of the group of the diuretics and its specific adverse effects. We know, I am not going into details. So thiazide-like diuretic, they cause hyponatremia, hypokalemia, hypomagnesemia. They can increase the uric acid level and can trigger the gout attack. They can increase the calcium concentration, though these risks are less with the thiazide-like diuretic like chlorthalidone, indamide, but still there is some evidence. Loop diuretics, they reduce potassium, magnesium, calcium, as well as sodium, and there is another additional risk factors of ototoxicity and dizziness. Potassium-sparing diuretics like spironolactone, eplerenone, they cause hyperkalemia, in contrary to the other thiazide and loop diuretics, which cause hypokalemia. And spironolactone, on the other hand, can cause gynecomastia. Dihydropiridine, this is the calcium channel blocker adverse effects. So calcium channel blocker, we know two major groups, dihydropiridine and non-dihydropiridines. So dihydropiridine commonly cause tachycardia, peripheral edema, and gingival hyperplasia. Verapamil-diltiazem, if it is dosed over the appropriate need, then it can cause bradycardia, constipation, AV block, gingival hyperplasia, headache, flushing, and edema, but though occurrence is less frequent than the dihydropiridine. Beta blockers. So adverse effect is very common with beta blockers, especially non-selective beta blockers like propranolol, sotalol. They can cause bronchospasm, especially we have to use it very cautiously with asthma and COPD. It's better to be avoided. And selective beta blocker, though it can be given in those asthma COPD situation, but it still metoprolol, atenolol can cause bradycardia, and it should be avoided in peripheral vascular disease. And neurologically also, it can produce some fatigue, vivid dreams, nightmares, and selective beta blockers like beta blockers have vascular properties like carvedilol that can cause reduced glucose tolerance, and often there is increased triglyceride. This is the very commonly used drugs like ARB and ACE inhibitors. So ACE inhibitor, we know that it can cause dry, irritating cough and angioedema. Irritating cough is very common, approximately 30% of patients, and angioedema, it is less than 1% patient, but if it happens, it is very serious. Hyperkalemia is another issue. ARB also can cause this hyperkalemia. It can cause skin rashes and myalgia, leukopenia, neutropenia, etc. So what is these different studies done in India? What is this different? I'm telling in very briefly. So this study has been done in the South Delhi Hospital, and a high percentage of adverse drug reaction has occurred in the middle-aged and female patients. It shows that combination therapy was associated with significantly high occurrence of the ADRs. So I have mentioned that often we start treatment with a single drug, but as the years goes on, we have to add another agent to control the blood pressure. And combination therapy actually tends to increase the occurrence of the ADRs. And cardiovascular adverse effects actually constitute major component, followed by GI and respiratory complex. Beta blockers were the drug category which is associated with the majority of adverse drug reaction as per in this study, followed by ACE inhibitor and calcium channel blockers. And this is a study done on the Coimbatore. Once again, here also female hypertensive population was found to be more susceptible to ADRs. And among the organ system, once again, cardiovascular ADRs constituted major component, and followed by gastro and respiratory. And most commonly identified ADR was peripheral edema due to amyloidemia. Actually, CCP-related edema is caused by peripheral arterial and pre-capillary dilation without commensurate dilation of the venous or post-capillary circulation. And correction of edema is done by physician with the dose reduction or drug withdrawal. Actually, there is no specific antidote to reduce the peripheral edema. And the second most common ADR was ACE inhibitor-induced dry cough. Here, beta blocker use is not so much significant. That's why beta blocker induced adverse effects is not given in the first two places. Another study in Bhubaneswar, and it shows clearly that as you increase the number of the, as well as the year, there is increasing age of the patient, number of ADR is also high. It is highest in the 51 to 60 years of age group and lowest in the 31 to 40 years of age group. So probably number of drug was high in the 51 to 60 years of age group. And here also number of ADR was highest with the calcium channel blocker, probably peripheral edema due to DHP group of calcium channel blocker. And here also female preponderance was clearly seen. 50-65% ADRs was provided from the female. And one of the important reflection of the study was CCP were the common group of antihypertensive used drug associated with ADRs, and amlodipine was found to be the commonest drug associated with ADRs. So it is not harmful, but actually the occurrence is reported and peripheral edema. And most common individual ADR was headache, which was seen in almost 21% of the patient. So it is across the drug group. And peripheral edema is also one of the common ADRs seen with the use of the CCP. And this study shows that according to WHO causality assessment, 53% almost ADR were probable. Okay. So that means they were actually reversed when the drug was discharged. And my next study, it was also an university hospital in New Delhi, and the studies also showed that females have more probability of having ADRs related to the antihypertensive therapy. And among the organ system, CNS adverse reaction constituted a major component there. Calcium channel blocker were found to be the most frequently associated drugs. And this another study outside this India was Nigeria, and it is actually I'm picking up this data only. So it shows that as you increase the number of the drug, percentage of increase developing or chance of having the ADR is more. So if you are giving one antihypertensive, chance of ADR is 10%, whereas you are giving 3, it is 21%. If you are giving 4 medicines to control hypertension, chance of ADR is also 32%. So to summarize, ADRs can have a determinant effect on patients' well-being and the overall healthcare system. And among the antihypertensive, ADR reporting were more with the beta blockers and calcium channel blockers. In different study, there is some variation. Some says it is beta blocker more, and some says it is calcium channel blockers more. But actually, depending on the usage, we can see calcium channel blocker induced peripheral edema is actually the most common adverse effect reported. And ADR occurrence was reported more with the combination therapy as compared to the monotherapy. ADR reported more in female as compared to male. Reason I do not know actually. So among the organ system affected, cardiovascular ADRs constituted a major component, followed by GI as well as respiratory complaints. And some studies show CNS symptoms like dizziness, headache, and sedation. So take home message is pharmacovigilance is dealing with the adverse drug reactions and it is considered among the leading cause of morbidity and mortality. And that's we should avoid actually if we can report properly and we can address the patient's problem of continuing their medication so that we can change the medication dose as well as the medicine so that they can continue their medicine, because our aim should be to control the blood pressure and we have to ensure that compliance is not compromised. So unless patient is continuing the drug, we cannot reach the blood pressure goal. So we have to routinely ask the patient for their adverse drug reaction and we have to take proper action. So ADR monitoring needs to be done in hospital setting continuously so that untoward effect caused by different medicines can be identified and documented. And monitoring of ADRs is more important in case of hypertension as it is a chronic disease and patient likely to take the medicine lifelong. And of course, patient is also suffering from multiple comorbidity and lots of drug interaction is also possible. That's why chance of detecting the ADR is also more as the patient is getting older.
Thank you, Abhishek. Have a nice presentation. Now, Rohan is very clear. They have Abhishek wrote, they have combination therapy, when it gives very more chance of area. The another thing is we have to give most of the time combination. So, it is a must that whenever we are giving antihypertensive drug, we should be very cautious and we should do pharmacovigilance study.
Yes.
Anything, one thing what we could see that younger generation is thinking both pharmacology is different. We are old pharmacologists who used to think in a basic pharmacology, but they are pushing to very different. I am very happy that they are thinking pharmacology in different way and they are enlightening us. We are learning so many things from them. Thank you all.
Respected Professor Abhijit sir, and Abhijit sir does not need any introduction. So, sir, please.
So I'm not in favor of keeping you away from your dinner any longer. So Rohan, we have 2 minutes then.
Sir, little unfair.
Okay, 2 plus 2. I've doubled the allowance. So, ladies and gentlemen, there was a time when we read and we still teach our students, these are the antihypertensive drugs. When you use them, you have to know how much blood pressure they reduce. These are the main adverse effects. Now, after listening to all these things going on around, that we have to control blood pressure at night, early morning, with smoothness and control, 24-hour monitoring, exclude all the secondary causes, etc., etc. It seems that for an average practitioner, the treatment of hypertension is going beyond his intelligence. We have to make use of artificial intelligence in the selection and use. But jokes apart, one of the practical problems which every practitioner in the real world faces is the problem of adherence to medication. Particularly, we are increasingly encountering hypertension as part of the metabolic syndrome. So patients on antihypertensives, lipid-lowering drugs, antidiabetic drugs, etc., etc. So very complex disease. And unless we are able to rationalize the adherence part, everything comes to naught. So, Rohan, just to introduce one very briefly, he's a young and upcoming engineer who, along with his team of technical experts, they are trying to bring some devices which would be of importance to patients who are receiving chronic medication. For instance, they are trying to innovate technological solutions for medication adherence. One other area where they are working on, which I know, is they are trying to devise some devices for monitoring autonomic nervous system function. So they have won a Government of India grant to go ahead with their device, which has already crossed the proof of concept stage. Rohan, up to you.
Thank you. Thank you so much, sir. Thank you so much for this wonderful opportunity. Well, I am so greatly underqualified to speak anything about antihypertensive therapy that I won't even try. I will just get into the various technological interventions regarding adherence, some specifically for the hypertension, but typically for chronic diseases. So we all know I'm sorry, the top part is not visible. So the typical graph of halves for hypertension, that is half are not detected, of that half are detected but not treated. Typically 12.5% are poorly treated and 12.5% are well treated. So the aim of these technologies is to basically transform the 12.5% who are poorly treated towards the well treated 12.5% and stand with a strong 25%. So we all know with the new and upcoming devices, which everyone almost finds at home, that the monitoring of blood pressure has become far easier these days than it was even 10 years ago. However, only monitoring is not the end of the solution. As the great Dr. Cook said, drugs don't work in patients who don't take them properly. So in order to help those patients who can afford the drugs and want to take them properly, we have some certain technology interventions that would help them for their post-prescription process. So these are the few interventions I would love to talk about tonight. So the first one, and possibly the most high-tech one of the few things that I would talk about, is the smart pill. It is basically a dissolvable sensor that that is inside your medicine. When you consume the medicine, when it goes inside, when you consume it, it sends a signal. There is typically a wearable patch, or there is either a patch or something wearable on your body. It takes the signal and sends another signal to your phone or any Bluetooth compatible device. One leader in this field was Proteus, who they even got the US FDA approval, but sadly the company got bankrupt and had to sell off their thing. But this is maybe holds the direction for revolutionizing adherence in the times to come. So then we also have augmented reality solutions, where the smart glasses are used to get using machine learning to convert learning the images and getting the directions for which of the medication to take and which to not take. Again, as in the previous case, here also, as you can all understand, the cost involved uphand is very high, and so it is another very good solution, but is something that Indian masses can rarely even think of enjoying, and this is still under research. So the another thing that is very commonly used, that is very easily available, is our various phone apps that we have. So these typically save a lot of your data regarding medicine consumption. They can save all your alarms, specific alarms for inhaler, for your various pills that you have. But then again, these are the best that they do are work as alarm clocks with no proper method of vigilance regarding the medicine consumption. Then there are also certain very good apps coming up which have instilled a aspect of gamification for the medicine consumption process that would give some upfront incentives for the user, the person who is using them, who has consumed the medicine, kind of an instant gratification. And even in some cases, they are attaching this with the health insurance people. So there is a long run system where there is points, and people who are properly adhering to their prescriptions are getting points there. So it's a proper initiative that can push people towards having better adherence. And there is the most used software app, I guess, these days, WhatsApp. In Brazil, there was a study back in 2020, and it was seen that people, even by simple adherence, inputs and instructions via WhatsApp, their adherence increases significantly. And then there are the few forms, MMS, the Moresky scales, the 4-point and 8-point scales. The issue there lies is these are typically self-reported adherence scores that the patient or the user says after they have taken the consumption. It's a self-evaluation basically. And the issue here is with the recall bias, because people generally tend to have a sweeter picture than the actual data. So there is a typical shift between the real scenario and the data that we capture. And there are the very old school methods of writing the timetable on the envelopes and the typical nurses chart, which although very cheap, very useful for keeping a tab, keeping a score of what medicines have been consumed, but still the crucial factor of actually tapping down on the medicine consumption, it somehow misses that. There are perhaps the most frequently used technology intervention for medicinal adherence, these boxes, which I guess almost every one of us have at least one at home. They are the pill organizers, very easily affordable and available, around 300-400 rupees a piece. Typically, at the best part of adherence they give is they have an alarm installed inside them. But one of the very difficult to accept things they do is they ask you to put different types of medicines outside the blisters inside the same unit and store them for prolonged periods. I don't know whether CDSU or any other body would be able to, approve or even like this practice in particular, but this is typically found in our households. So this is the better versions of the pill organizers that are available, the pill dispensers, smart systems like Levy, Hero, Pillow. These are typically very high-end and state-of-the-art consumer electronics. But again, the affordable and the accessible ends are not really at all suited for the Indian masses. So the problem stands. So this is basically a typical analysis of why the current systems, though having a lot of pros for each individual system, have one or the other major lacking, as that results in us all agreeing that there is required a standard system for adherence. That is what we are trying to do. I won't be advertising ourselves too much, or sir will not be very happy with me. So I will just try to briefly introduce you with what we are developing for the past almost 4 years now. So it's called MedPer, comes from your personal medicinal helper. It's a hardware unit where you need to store your medicines. There's a timely alarms, light and sound indication is there, and the entire data can be accessed via our app is there, our server is there. Anyone sitting anywhere in the world who has the access can get it. The difference that we have from these smart devices, from the purely IoT devices, is we do not need 24-hour Wi-Fi support. Once a fortnight Wi-Fi support is enough for us. And also the end user does not need to have a phone or a smart device. The caregiver can visit once a week, once a fortnight, and can help them in their post-prescription journey. And we have gone here and there, got a few government grants for this. And also, okay. Oh, I thought that was an alarm for me. Anyway, so last year we took up a challenge on ourselves to have at least one adherence awareness seminar a month, and we had 12 seminars around for the 12 months of last year. And I'm so proud to say that a lot of you who are here have been either audience to us or have been speakers in the sessions. And I'm really grateful to my mentor, Dr. Samajdar, who has been the biggest push who has made this one possible. And also one another thing which makes such a digitally enabled system essential and very important for the days to come is the great push that our government is giving towards the Ayush Bharat digital mission in digitalizing the entire healthcare, for which I believe such smart devices would be affordable by the masses typically, would be very important for us in the days to come. I would like to end with my friend, Mr. Bart Simpson. Though it's not advisable to make your patients go through this kind of an ordeal, but it's good to have, better to have technology so that this kind of ordeal will not be needed. Thank you.
So, thank you, Rohan. The best kind of medication adherence rate so far is a nagging spouse or parent or dependent will tell you to catch up. So that still holds true. But we are going to a society which I have seen in my practice is that You don't have such lagging people at all. You're absolutely alone. And more people, especially elderly people like that, they are alone and often with cognitive problems. So we really have to think that even in our social conditions, we need some kind of support. Now, this is the technology solution that Rohan and his team is developing. There are other people who are working on similar concepts. Now, whether these gadgets are going to be useful or these gadgets will be passing time, only time can tell. But it's important that in any treatment of any long-term diseases, we side by side to selecting the right drug and prescribing it in the right dose, right time, etc. We also have to think what is the right way to make the patient take the medicine. So Rohan, good luck to you and your team. Yes, only one.
Thank you everyone. And now we also want to thank our online
delegates who are present constantly. So almost 35 delegates were there. Now almost 17 participants are still there. So we don't have any facility for Zomato or like that to send you your dinner. So hope you will enjoy your dinner at your home. So good night, everyone. Thank you all. We thank our sponsor of this today's event, Dr. Reddy, for organizing this event very smoothly and nicely. Thank you very much. And special thanks to Inovocare also, Healthsoft Solution, who had supported us with different types of logistic measures, including preparation of certificates and other things. So we are really thankful to Mr. Rohan Tripathi and his team. Thank you.